Hello and welcome to this session on vaginal breech birth. So before we start, I'd just like to cover some key learning points that we should be covering through this presentation. The first point is just talking about women with a breech presentation should be provided with information regarding the risks and benefits to both vaginal birth and caesarean section when deciding their mode of birth. It has been recommended that during labour, continuous electronic fetal monitoring has been associated with improved neonatal outcomes. Practitioners that are managing vaginal births and breech presentation at caesarean section should be trained and competent in managing these births, and that includes having hands-on simulation training. When thinking of progress in labour with a vaginal breech birth, we should ensure that there's adequate descent in that passive second stage prior to commencing pushing for the active second stage. So maternal position should depend on maternal choice, but also very important that the practitioner is experienced in that position as well. We talk about a hands-off approach as much as possible, but of course this is only as long as there's progress in labour and we can see that there's evidence that the fetal condition is satisfactory. Thinking of choices of manoeuvres and techniques, very important that we're training practitioners in these techniques should they need to be used. So moving on to our incidence and risk factors associated with vaginal breech birth, the incidence of breech presentation at term is about 3 to 4% of births. It's associated with a higher perinatal mortality and morbidity, and those include birth asphyxia, birth trauma, prematurity and congenital malformations. And you can see in the table there's quite a large group of risk factors that are associated with breech presentation. Thinking of complications of a vaginal breech birth, there's again quite an extensive list. You've got cord prolapse as a result of the irregular presenting part. Thinking of injuries to the infant, you've got intracranial hemorrhage, brachial plexus injuries, rupture of the baby's liver, kidney or spleen, dislocation of the baby's neck, fractured clavicle, humerus or femur, and ultimately intrapartum death. So thinking of these risks, if a woman with a breech presentation isn't actually diagnosed till she presents in labour, then this increases the risks even more. It also represents quite a challenge for your obstetric management and also that shared decision making with the parents. It could also be seen as a missed opportunity to offer the woman the option of having external cephalic version if she's not presenting with her breech until she's actually in labour. The Pregnancy Outcome Prediction Study was a study of nulliparous women, identified that if we were to do a universal late pregnancy ultrasound scan, this would virtually eliminate undiagnosed breech presentation, and that would be expected to reduce fetal mortality in breech presentation. It would also seem to be cost effective with ultrasound scans per woman of £19.80. However, this is not currently standard care in the UK, but the implications in terms of staffing and training are currently being considered. So looking at other studies, the term breech trial, which was run back in 2000, is probably the most well-known trial. I guess the key findings at the end of this was that after a 2-year follow-up, it was unclear if long-term benefits of the child being born by planned caesarean section actually outweighed the maternal risks of additional caesarean sections. Subsequent publications, there was one Dutch study which looked at 58,000 breech babies. They found that you needed to conduct 338 caesarean sections to prevent one perinatal death. The Premoda trial looked at the outcomes of mortality and morbidity and found that they were about equal between the two modes of birth. So, considering the difficulties with decision making when a woman presents in labour and has her breech presentation diagnosed for the very first time, the NICE guidance produced in 2019, which was for women with existing medical complications, includes decision-making guidance for women in these circumstances. The decision-making is very much based around how difficult it is when a woman is late in labour to make those decisions about the best mode of birth, and weighing up the risks and benefits of mode of birth and the risks to the mother balanced against the benefits to the baby. The guidance also acknowledges the requirement for training to support undiagnosed vaginal breech birth. So moving on to some current research that's currently underway, the OptiBreech project is a project that's an NIHR funded study which is optimising care and options for breech presentation at term. The study is being run by Sean Walker, and the training incorporates a physiological approach to the management of labour. And the key thing is that they're recruiting at the moment units. It's going to be quite a while before there's results, but it's exciting that there's actually some current research underway to perhaps answer some of our questions about the best positions. There's also a retrospective cohort study of the In Time training programme, which was simulation-based training using the prompt model, where practitioners were provided with a scenario of a woman with an undiagnosed vaginal breech in labour, and they found that the training was associated with improved neonatal outcomes, with more senior accoucheurs feeling confident and improved documentation. So going on to our national guidance, we have the RCOG Green Top Guideline that came out in 2017, and essentially this discusses about planning for vaginal breech birth, and again it discusses the importance of women being informed of the risks of perinatal mortality. It also identifies that where possible, women should be offered ECV unless there's an absolute contraindication. The guideline also emphasises the importance of the presence of a skilled birth attendance for safe vaginal breech births. So going on to the practical management of our planned vaginal breech birth, certainly the essential components, if you are planning a vaginal breech birth, are that you've appropriately selected your case, that the clinical care that you're going to provide is evidence-based and following the national guidance. You have skilled birth attendants who are skilled in all of the evidence-based care. The birth should take place in hospital with facilities to be able to transfer to an immediate caesarean section if needed. You also need to be able to provide continuous electronic fetal monitoring. Water births are not recommended, and the other key factor is that you have a time limit, so a maximum of a 2-hour passive second stage. So returning to our unplanned vaginal breech births, the RCOG guidance states that breech presentation at term is not diagnosed until labour in about 25% of women. So again, emphasising the difficulties with decision making for these women. They recommend that management should depend on A, the stage of labour, the risk factors, the skill of the team, and of course the woman's wishes after appropriate counselling. So, thinking of the practicalities of the first stage of labour, the recommendation is that they should have continuous electronic fetal monitoring throughout labour, and that's including if you're transferring to theatre for caesarean section. Very important that the fetal monitoring is continued right until the baby is born. It's important that there's adequate progress and descent of the breech in that first stage of labour. Thinking of your second stage of labour, again, we recommend electronic fetal monitoring right through until the baby's born. It should be managed by a practitioner who has had adequate experience in training and they are skilled in vaginal breech birth. And descent of the breech to the perineum in that passive stage should be recommended. And the breech should be visible at the perineum, and that should be your trigger for then conducting the active stage of labour. The RCOG recommends a semi-recumbent position or a forward-facing sort of squatting all fours position, but that position is very much dependent on maternal preference, but also the experience of the attendant again. There should be early recourse to a position that the attendant is comfortable with, and certainly early recourse to a semi-recumbent position if manoeuvres are required, particularly if that is the position that the attendant is most confident in. Once the breech is visible, encourage pushing. And we often say a hands-off approach, and that is absolutely fine as long as there is no delay or evidence of poor fetal condition. An episiotomy may be considered to facilitate the birth if needed, but it's not routine. If there is any delay, then assistance is required. And of course, handling the baby minimally and only over the bony prominences of the iliac crest is a way to reduce the risks of soft tissue damage. A neonatologist should always be present at the birth if they're available. So signs that the birth requires assistance, certainly if there's evidence of poor infant condition with a lack of tone, poor colour observed in the infant's body, and that's the one thing that you can see very easily with a breech presentation, is the condition of the baby. If there's a delay of more than 5 minutes from the birth of the baby's buttocks to the birth of the baby's head, then there would be assistance required. And if there's a delay of more than 3 minutes from visualisation of the baby's umbilicus to the birth of the baby's head, then again assistance is required. Delay can commonly be due to extended arms or an extended neck, and so again manoeuvres might be required to resolve these. Thinking of difficulties with delivery of the baby's head, suprapubic pressure can be something that is encouraged to encourage flexion of the fetal head, and you can see that in this picture here. We have a poster which covers the manoeuvres that may be required if assistance is needed, and that poster can be displayed in easily available in clinical areas and may be useful for training. And there's also a QR code on the poster which links you straight to the prompt vaginal breech birth video. Documentation is very important, and this is an example of a vaginal breech pro forma that you would complete. Obviously, whatever you use in your unit, be familiar with that pro forma and certainly practice using it when you're doing your training sessions. So now we're going to show you the vaginal breech birth video, which shows all of the manoeuvres in more detail, and then hopefully in your practical sessions during your local prompt day, you'll be able to practice these on your mannequins.
So today we're going to talk about some of the manoeuvres required to deliver a breech vaginally. Now, even though caesarean section is much more common for breech, it still is an issue, and we need to train to deliver breech vaginally wherever we can, particularly when the woman arrives in advanced labour. So the first thing is, as the mother's pushing, just really keep your hands off the breech. Don't try and pull. The more you pull, the more likely you are to get a nuchal arm. This mother's really doing well. So you can see that often the legs will deliver spontaneously. However, if they don't, then it's worth just flexing the knees and bringing the legs down. Again, with this side, flex them, bring it down. Now then, put your fingers in the groins of the baby with your thumbs over the sacrum. It's really important then just to let the baby come down till you see the scapula. You can see it just there. rotate the baby round in love sets maneuver. Then with the same finger as the same side as the shoulder, put your finger over the baby's shoulder into the antecubital fossa and flex the arm down. Now I recommend then roll it round again, use the other side's finger to get into the antecubital fossa and again flex the arm down over the chest. Then with the pushing from the mother, pushing down, you can see the nape of the neck coming down. I would then use Morrisseau Smelly Vite for this. So for Morrisseau Smelly Vite, it's important to rest the baby's abdomen on your forearm. On the lower hand, press on the cheeks of the baby, and the upper hand press on the occiput to maintain flexion. So keep the chin on the baby's chest so the head doesn't become overextended. As the mother's pushing, then what I would do is stand up and maintain the flexion and deliver the baby in a J shape like that. Sometimes the head doesn't descend enough for us to do Morrisseau Smelly Vite, and it's important to have a think about manoeuvres that can help descent so that we can deliver the baby, and particularly the aftercoming head. So one of the things to do is suprapubic pressure to maintain flexion of the baby's head. So Kathy, if we can do that, and that in of itself can be a useful manoeuvre. However, sometimes that doesn't work either, and it's important then to think about what is available for next steps. So Kathy, if you can get your assistant to hold the baby up whilst you place the blades. So it's a standard application of Keelan's. Just pop them in laterally, just like you normally would. Let the blades come down a bit. And again on this side, again laterally. Just let the weight of the blades come in like that. Just let the blades settle in. Join them together. And Kathy, I'm going to take the baby now, that's great. Let's rest the baby down. Then just like Morrisseau Smelly Vite, put your hand to flex the baby's head at the occiput and just stand up like a J shape to help to facilitate the birth of the aftercoming head.
So finally, we just need to cover unexpected breech birth that may occur outside of hospital. So very important that you call for help. You want a second midwife, you want paramedics on the way. And the aim is to transfer into the obstetric unit if at all possible. If birth is imminent, then clearly that's going to be a difficult thing to do, and you need to contact the obstetric unit and get their support and guidance. If you can, get them on loudspeaker phone so that they can provide guidance to you and you can speak clearly to them. The principles, if you need to assist the birth, are exactly the same as we've covered in the slides and in the video. We cannot stress, though, that it's a hands-off approach, but only if there's no delay and that the infant's condition is looking satisfactory. Clearly, you need to prepare for neonatal resuscitation, and you probably won't have a neonatologist there, so have that second midwife ready with the resuscitation equipment. So really important that you continue communicating with the maternity unit team, thinking of positioning of the mother, important to encourage gravity and descent of the baby, but of course the midwife needs to be confident with the position that she has the mother in. Ideally aiming to keep the mother as upright as possible, and you could consider all fours. It's important to use your professional judgment and document the reasoning for your decisions that you've made. Remember, if complications develop, it may be necessary to transfer in mid-birth. You'll have your paramedics on standby, but this can be a traumatic situation for both the parents and the staff. Once the baby is born and mother is stable, this is your opportunity to discuss with the parents what happened during the birth, and also your chance to debrief with your team as to things that maybe could have been done better, but also celebrate the things that you did well. Thank you for listening.